When undertaking examination of the knee, inspection should occur with the patient sitting, standing and walking. As well as the normal observations, it is important to note whether there is any genu valgum, knock knee, or genu verum, bow leg. Each tibia should be inspected to ascertain that there is no tibial torsion. Take particular notice of the popliteal fossa because fullness indicates that a Baker's cyst is likely to be present. Screening of the knee requires walking and deep squatting. If the patient is able to undertake a deep squat with their heels flat on the ground, then it is extremely unlikely there is any significant knee pathology. Walking on tiptoes is a further screening test. Palpation of the knee should be systematically undertaken, paying particular attention to the joint lines, the medial and lateral collateral ligaments, the patellar tendon and its insertion into the tibial tuberosity, and to the synovium above the patella. Movements are generally undertaken while sitting over the edge of the couch. Flexion is expected to reach 140 degrees, extension should be at least to neutral position, and sometimes to 5 to 10 degrees beyond neutral. Normal internal rotation is approximately 30 degrees, and external rotation 40 degrees. When testing for an effusion, the initial test which is generally done is the patella tap. As can be seen, fluid is milked down from the suprapatellar bursa into the knee joint and then held there by a firmly clasped hand immediately above the superior border of the patella. If the patella has been displaced from the femoral condyles by an effusion, then the tapping may cause it to hit the condyles. If this test is negative and there is no gross swelling, then the bulge or wipe sign is undertaken. The examiner wipes any fluid out of the medial gutter, and then the knee is observed to see whether or not there is any bulging into the gutter as the effusion returns. Quadriceps wasting should be tested for in any knee injury which is more than 7 to 10 days old and already not substantially improved, because there will already be muscle wasting if there is internal knee disruption. This wasting first occurs mainly in the vastus medialis muscle, but later affects all of the quadriceps muscles. The test is done by measuring an equal distance above both tibial tuberosities, marking identical spots on the thighs. For injuries that are less than 30 days old, this mark should be over the vastus medialis muscle, so a point which is 1 to 2 centimeters above the superior border of the patella is chosen. If the injury is more than 30 days old, then the point of reference should be between a third and halfway up the thigh. The circumference of both thighs is then measured at the points marked. A positive finding occurs when there is a 1 centimetre or greater discrepancy between the measurement on the side of the injury compared to the other side. With all of the special tests, care is taken to minimise patient discomfort by applying smaller forces initially and then increasing these if no pain is caused. Once pain has occurred, the test is positive and is discontinued. The first of the special tests is testing for the collateral ligaments. As is being demonstrated, this is done with the knee flexed to 30 degrees. Medial collateral ligament injury is tested by applying an abduction force to the lower leg, while the lateral ligament is tested by applying the opposite force. When testing the cruciate ligaments, a skyline or lateral view tests for whether the posterior cruciate ligament has been ruptured. In the positive test, the lower leg will be dropped back on the thigh compared to the normal position, and a step will be clearly obvious. This test can be done either with the patient having their feet flat on the bed or with their legs elevated with the hip and knee being flexed to 90 degrees. The examiner then sits on the feet and supports the thigh with one hand, and then uses the bottom hand to pull the tibia backwards and forwards, seeing how much anterior and posterior movement can be obtained while comparing one leg with the other. If there is a ruptured cruciate ligament, then there will be greater movement detected on that side. In the Lachman test, the knee is flexed to 30 degrees and the femur is stabilised, either by the examiner or commonly with the assistance of a third party. The tibia is then moved anteriorly and posteriorly, again comparing the amount of movement on each side. A positive test for cruciate damage is increased mobility on one side compared to the other. There are many variations on McMurray's test for meniscal tears. Whichever method is chosen, it is important that the test is conducted from full flexion to full extension, and the foot is rotated in the opposite direction to the meniscus being tested. As can be seen in the demonstration, when the medial meniscus is being tested, then the foot is held in a laterally rotated position. The next test is an attempt to pick up the synovium, which will only be possible if the patient has synovitis. This is called Solomon's test. The patient has now turned over and is lying prone, so Apley's grind test can be done. This is a further test for meniscal damage, and as is demonstrated, the knee is flexed to 90 degrees. Pressure is then applied to the heel, transmitting down the tibia. The foot is rotated medially and laterally. This test should be started with light pressure, which is slowly increased, with the testing being stopped if this manoeuvre causes pain. In the Apley's distraction test, the lower leg is lifted to see whether pain is caused over the medial or lateral collateral ligaments, which will occur if there is a strain to those ligaments. As is demonstrated, lying prone provides another way by which McMurray's tests can be done. The same principle outlined earlier applies, with the examination extending over the full range of knee movement, and the foot being rotated in the opposite direction to the meniscus being tested.